So, welcome to this Patients Association session, Missingness in Exploring Why Patients Miss Multiple Appointments and How the System Can Support. I am Sarah Tilstead, Head of Partnerships and Involvement at the Patients Association. Today, I'll be joined by Dr. Susan Langridge, a Deep End GP, Andrea Williamson, a GP, Professor of General Practice, and the lead for the Missingness in Healthcare project. And lastly, Caroline Norman, who is the HARP project manager, which is Health Access for Refugees at the Refugee Council. And if we want to put down the slides, please. Fantastic. So a bit about today. I think we can agree that the current one-size-fits-all approach to appointments is clearly failing patients, clinicians, and the system as a whole. And the Patients Association work with the Royal College of Physicians on outpatient services, for example, indicated digital changes and admin challenges can have issues for patients when attending appointments. We also did some work with NHS England to understand more about why people miss their appointments. We used local level data, national insights, and learn from good practice. And I asked two of our Patients Association members to present to clinicians involved in this work and explain why they personally miss appointments as patients. And I think, in a quote from the traitors, clinicians were flabbergasted by what they were actually hearing for why they were missing those appointments. And as you know, missed appointments are often closely linked to health inequalities. So, for example, patients from marginalised groups are more likely to miss their appointments, and that includes people with disabilities or who have English as a second language, as example. And an interesting point of note, and we've seen this with our recent work on improving health equity for patients with blood disorders and cancers, is that a growing number of patients have missed NHS appointments due to worries about the cost associated with attending appointments. So that, something such as simple as paying for petrol. So in today's session, we'll look at how we can action the issues faced by patients through creating a more flexible, personalised system that recognises the reasons why patients miss appointments. From admin failures at the system level to personal reasons for patients, such as not being able to find childcare or missing a phone appointment due to lack of mobile reception. So we'll go to our speakers now, who are the experts on this topic. And I'm going to start with Andrea, who has a couple of slides. So over to you.
Thanks so much, Sarah. Yeah, so I'm a GP by background, and a founding member of a project called GPs at the Deep End Scotland, where we're a collaboration of GPs who work to serve the most socioeconomically deprived communities in Scotland. And this research that I'm going to talk about a wee bit now really comes from that work, and having worked in inclusion health settings for a long period of time, because we were kind of aware that this was an issue both for patients and for practices. But when we went and looked at the research, we found that there's lots of counting being done, but very little being done to try and understand what is going on. So if you can start with the first slide, please.
I think oh, there we go. I was going to say we're having some technical difficulties, but I think we're
there now. Yeah, no, that's great. So first of all, we wanted to actually think about, so you can go back one slide. I think there's one slide before that. That's great. Thank you. So what we wanted to do was, so we were aware that, lots of people will miss one appointment, but we weren't so sure about what was happening when people potentially miss more than one appointment. And that was something that we picked up from our clinical practice. So we define missingness to begin with as the repeated tendency not to take up offers of care such that it has a negative impact on the person and their life circumstances. So the first bit of research we did was basically got data on from 136 Scottish representative GP practices. And so this was looking at over 500,000 patient records, all anonymised, and almost 10 million consultations. And the first thing we did was we looked at patterns of missed appointments. So we found that actually more than half of people don't miss any appointments at all. A good proportion will miss one, but then when we look at this in more detail, about 19% will miss more than 2 appointments. And that's averaged over a 3-year period to try and take account of health crises and social concerns. And you can see that the sort of bar chart on the right shows the kind of profile of the numbers of missed appointments across some people. Next slide, please. So then what we did with all this data was we linked it in with records across into secondary care, so outpatient appointments, hospital admissions, emergency department attendances, and also looked at the coding that was in these GP records to look at health conditions and other aspects of people's social circumstances. And we basically found, and this kind of turns things on its head, because in the past, clinicians anyway have tended to think that people miss appointments because they don't need them. But actually what we found was that people who are in the high risk of missingness category, and that's the wee dots on at the bottom of each of these graphs that you can see, those people actually are characterised by having poorer health. They've got more long-term conditions. They're struggling more with the work they need to do to manage their health, which we call treatment burden in the health service. They have often complex social circumstances, but the bit of it that really shocked us was that people tend to have higher premature mortality. Now, that means that people die at a younger age than they should. And the graph on the right is the sort of representation of that from the stats. So the people who were more likely to miss appointments, looking at all sort of causes of mortality, were more than 3 times likely to die. But when we look down at buried down into the people who had a mental health condition recorded in their GP notes, then the people who were in the high group had a shockingly high excess mortality. So that really worried us. Apart from looking at this pattern in general practice, we looked at it across into secondary care, as I mentioned, and we basically found that when people are missing in general practice, they're more likely to be missing in secondary care as well. So they're more likely to be missing their outpatient appointments, and they're more likely to not manage to stay in hospital until their care plan's completed, and we call that an irregular discharge in the health service. But the thing that we were again quite surprised by was that we found that patients weren't more likely to then be seen in emergency departments. They were just not being seen. So we were really worried about that. And so that then took us on to the next bit of work, which we'll talk about later. End of slides. Thank you.
Thank you. And now I'm going to go to Susan. Susan is there. She just got some video difficulties, so we'll try and see if it's working. So far, so good, but over to you, Susan.
Hello, good afternoon. Thank you, Sarah. Yes, I have the technology of the video is not agreeing with me, so I may switch off my video if it bounces around in a very annoying fashion. So just to introduce myself, I am a GP working in Greater Glasgow in Postle Park and Woodside Health Centre. At the last count, we were the number 18th of the most deprived practices. And yes, I was also a founder member, part of the original steering group set up by Graham Watt to look at the problems of particularly deprived practices and what we named the deep end. And we, in fact, came up with the idea of the community links worker. So that's a bit of an introduction. So I have a very small practice and currently I'm single-handed. I've actually looked after my patients for, I'll just say over 30 years. It's actually quite a lot longer than that. I have a practice manager who's been with me since she was in her mid-20s, and she's had her 40th birthday and her first child. So we keep a good small team, and generally people stay with us for a long time. Andrea's findings about the effect of what we're calling missingness. I have to say, observationally is not a surprise to me. It's been noticeable in general practice that those with the most need do tend to avoid contact with medical services. It's a paradox that quite a lot of people don't understand. But when you've been in general practice for a long time, you do get a feel for it and an understanding of it. It's not a pervasive truth, but it's certainly a very common truth. I could go into the reasons behind this, but what I'll tell you is that now, personally, for my practice, I say this as a truth, I really hardly have any DNA appointments. When I did have DNA appointments, I approached it in a proactive way with staff to say, well, okay, really just let's ask the patient why they didn't attend. Let's understand. And part of a reason why a patient, what we found, doesn't attend is because of the many practical reasons, but it's allowing them to explain, and you have the understanding and the conversation that then actually allowed that to disappear, because then there was a mutual conversation with staff about, well, okay, this is the impact with us, so at least, tell us. So it's not that patients don't cancel an appointment, but they do cancel and they let us know. We thank them for this. These sound very simple human interactions. And I think part of the problem is because we're all so busy and time poor, we forget to do these things. But what we also have to remember is what we're doing is we're investing upfront time to save time further down. Because after all, as Andrea has pointed out, patients who are in the category of those who tend not to attend tend then to have something seriously wrong with them. And they will reappear in crisis, either to myself, or yes, they do in A&E, although Andrea's pointed out they don't. They are then found in extremis, and that the mortality is high. And there are repercussions in that of itself, as well as the fact that this is simply not what we're setting out to do. It's not good practice. So we also find that patients in the same, they will not attend secondary care more than they will not attend the practice. So what we have now, and this is my daughter, Lisa, who has taken on this role, is someone who will actively, proactively see if a patient doesn't attend. Again, simply phone them to ask why and the understanding. And this is not in a punitive way. This is a key issue. One of the things that we don't do is put patients off for not attending. Yeah. That it's not that within the practice we don't have respect and boundaries about how a patient will interact with services. We do. This is like I say, like a family is what you would expect in human behavior in a family, right? Okay, you need to tidy your room. For instance, I say this in a sort of trivial way, but don't take this wrongly. I have a daughter, I love her to bits. But it is good for in the family for certain rules and certain discipline. So, if you cannot attend, let's find out. And therefore, once we have found out, what can we do to help you? And then this is a psychological conversation, and there are many reasons. But the point is, once the patient then feels understood and therefore cared for about why they haven't attended, that of itself promotes attendance, because it's then you are putting in the effort for the patient to then feel valued and cared for. And then part of one of the complex reasons why psychologically patients don't attend is because they don't care enough about themselves as a priority. So having somebody show how they care for them elevates. Now, there are also practical reasons. We've talked about English not being a first language. we talked about disabilities, we've talked about not having IT skills. I'll confess, part of my problem here with my camera bouncing, I don't have the IT skills to fix it. You know, I'm an
Maybe we
intelligent.
can come on to some of those a bit later. Yeah, some of the
Yes.
barriers and what we can do to.
Right. So I'll stop there. But that is, in practical terms, this solution that we have in place around and the other thing I'll just mention is what we also do often is ask the services to tell us when the appointment is going out to the patient, and therefore we can again make contact with the patient quite close to when the appointment is, and to facilitate that. And then if they can't attend, we can engage with the service in order to get another appointment. Thank you.
Thank you. And last but not least, Caroline.
Hello, my name's Caroline Norman and I work for Refugee Council, and I manage a project called Health Access for Refugees Programme, or HARP. And I'm based in Sheffield, but we cover Sheffield, Rotherham and Wakefield. And the main thing that we do is to run drop-in sessions in asylum hotels. So currently we're working in 2 asylum hotels for men, one in Sheffield, one in Wakefield, and each of them houses, I think, just under 300 men. So what we do is a weekly drop-in, which we just see as many people as we need to. We recruit lived experience volunteers, so we have people who either live in the hotel currently or maybe they've lived in the hotel recently. So they've got lived experience, they know what the barriers are to all aspects of health for asylum seekers. And I would say that the biggest issues that we have regarding attending appointments are not understanding what the appointment is for. I would say that the first appointment that people normally get after they've arrived in a hotel is like an initial health screening at the GP practice, and a letter comes which isn't really a letter, it's like a printed out appointment schedule. So it has no explanation of what that appointment is for. So they have no understanding. And it normally comes between 4 and 6 weeks prior to the actual appointment. And so they may have just arrived 2 weeks ago. They have a huge amount of paperwork, most of which is in English. They have piles and piles of paperwork. They have paperwork from the Home Office. They have the accommodation provider. They have migrant help paperwork. And it just gets pushed within the envelope that they have it in together, filed away, or maybe even thrown in the bin. Quite often when they arrive, they have a phone with no UK phone number. They only have a WhatsApp number, which may be from their home country or from France or whichever country they might have come through. So it's really difficult to stay in contact with them. So there's the language issue, but there's the understanding of what an appointment is for, or where it is. That people have no structure to their week or day when they first arrive before they've got into going to maybe English classes or whatever. So one day merges into the next and they're not quite sure when an appointment is. There's a big issue with very poor sleep. So in most cases, people share rooms with a stranger. People find it very difficult to sleep. So if one person, for instance, has got insomnia, or one person is phoning their family in the night because of the time difference, or just keeping different hours, people really struggle to sleep. And that's in addition to not being able to sleep because of mental health, because of trauma, etc. There are issues with transport to some appointments. So the GP practice is close to the hotel, but the hospitals are not. There's no help with transport costs. The accommodation provider will give a taxi if the appointment is more than 3 miles away. In a city like Sheffield, walking 2.5 miles is probably going to involve a lot of hills. It's not an easy walk. And issues with the transport, the accommodation provider books the taxis. They are often actually very, very late. So they book the taxis in advance. So people then get to their appointment an hour early because of them often being late, they book them early. So then they're sitting for a long time. People can't find their way in larger hospitals, and they don't have the language to ask. People have no data on their phone, so they don't have directions to a hospital, so they can't use their Google Maps or whatever if they don't have data. I think those are the main issues. I've worked in another hotel that was isolated from the city centre, in a more isolated area, which is closed now. And there they had issues with actually, getting to appointments with it being so far away and having no idea of their way around. Currently, the two hotels we work in are closer. And I think just generally a lack of anybody helping them to understand what an appointment is and where to go. And I can come on to what we do to help with that in the next part.
Brilliant, thank you. Andrea, I was going to ask you a specific question, but I feel that the three of you might have already answered this. So if there's anything in addition, I was going to ask you that obviously you've done some research. Was there anything that hasn't been mentioned that you found from your research about the specific causes of missingness in healthcare?
Yeah, thanks, Sarah. Yeah, no, there was. So we basically, this was an NIHR funded piece of research. And what we were trying to do was really get information, get data from as many people in different groups as possible. So we wanted to cover a whole range of clinical conditions, social context for people, inclusion, health context, which included people in the asylum system, to try and make what we found as sort of generalizable as possible across the whole population, like we did with our big data study, which was across the whole population. And yeah, lots of resonance from what Caroline and Susan have said. A couple of things just to really highlight though. So transport was in there, getting there was in there. Past experiences of healthcare are really important. So each contact a person has with the NHS really drives whether people will feel able to use the NHS the next time. So that's so vital across, so this is not just about contact with clinicians, it's across the piece. But I think there was a couple of things that really, really struck me in addition was that also patients just really feeling that the NHS wasn't for them. Like that was a really big theme. That maybe it wasn't necessary, maybe it wasn't helpful, appropriate or safe. And safety sort of really, I suppose, drives into the whole idea that, people often have psychological trauma in their background or are struggling with the experience of stigma. So they've been stigmatized before. And that really makes the sort of healthcare offer really, really complicated. But I think the final thing I wanted to say was just, historically people have been blamed for not managing to attend appointments. And I think our research certainly really turns that on its head, because what we found was that, and so beautifully illustrated by what Caroline's just said, unfortunately, is that people have got lots of competing demands with limited resources. So whether that's financial resource, family support resource, relationships resource, whether it is that people are actually just struggling to survive at that time, that's really what is driving missingness. It's not sort of, I'm not really quite sure what the ideas were that people used to have, but it really is, people know that the NHS is a precious thing, once they're settled in, and they know that healthcare is really precious. They're not wanting to not be available and use it, but they're just, the barriers, are just so high.
That's brilliant. Thank you so much for that. And Susan, I'm gonna come to you next. We can test out your video again, see what it's like. But I'd love to hear from you, your thoughts on the importance of reception staff and how critical you think they are in making it easier for patients not to miss appointments.
Oh yes, absolutely. Our reception staff are an absolute critical, valuable asset. And I think part of the reason because I've talked about how my reception staff will be involved in talking to the patients to understand why. So, and again, as Andrea has mentioned, it's this lack of blame. So we're not asking you to blame you. I was interested, Caroline was saying, again, lack of understanding what the appointment is for. Because at the end of the day, if you've got so many competing priorities, you don't, generally patients like this will not put themselves as a priority. So if they understand what it's for and why, and are given that. So the reception staff are absolutely critical. And in my team, my reception staff are my highly valued, it's so important that we have a relationship with myself, a practice manager, that reception staff feel supported, and they value the fact that they are given this trust and responsibility to have these conversations, and we exchange information about what's happening in people with their real lives. And therefore, this adds to the staff feel that they are making a difference. At the end of the day, I want to make a difference. They're there to help make a difference. And, I can't do everything. I'm sure patients would like that I did everything, but that's just not possible. So the reception staff who have the continuity and the knowledge of the patient, interestingly, patients will have different conversations with my staff and with my daughter that they wouldn't necessarily have with me, because somehow they maybe think that for whatever reason they didn't want to disclose to me, and that's fine. But the value of the receptionist being the person who's given that value within the practice to have that high level of autonomy and trust then flows through into the patient in terms of they're more likely to engage. So hopefully that gives you some idea of where we hope we're making a bit more of a difference in this.
Absolutely. Yeah, no, I agree with you. I think that reception staff are so vital in any service. I really do. So we'll come back to Caroline, and you mentioned that some specific reasons why asylum seekers and refugees perhaps miss appointments. But if there's any others that you want to mention, and if not, perhaps you could talk through some ways that people can make it easier to ensure that asylum seekers and refugees are not missing appointments.
Yeah, actually, there are a couple of things I didn't mention about why people miss appointments. And one of them, I think, is that if there is some reason that they can't attend, they don't know how to let the service know. Generally because of language and lack of confidence in making that call. And there's something about the lives of asylum seekers where they just don't have any agency, that people do things to them and not with them. So they just get sent appointments, like it might be with the Home Office, it might be with college. And an example is, last week I had a gentleman who said that he'd got his asylum interview, and it was on the same day as his initial health screening. And so he wanted me to change his asylum interview. And I said, this is not possible. This is the thing that we can't change, but we can change your initial health appointment. And he said, my life is more important than my asylum claim. And I had to say, look, if you don't go to your asylum interview, it's going to affect your life. So we had to sort it out. But the ability to prioritize, because he was anxious about his health, he wasn't able to sort of prioritize that his asylum interview was important, and that the health appointment could be made on another day. So they do get all these appointments at once, and they don't know which one to cancel or how to cancel it. They don't know that it can be rearranged. So that is a big issue in not attending. But I can give a really good example of how things used to work better, I think, for the initial health appointment attendants, in that each hotel has a group of welfare managers that work for the asylum accommodation provider who are contracted by the Home Office. In our area, it's Mears Housing. And we used to have, at one hotel, we had a really good worker from Mears who, when the initial health appointment letters came, she would take them, she would deliver them by hand to each person, and she would tell them what it was about. And she would either call an interpreter or she would ask another resident to explain who had good English. And then she would put it in her calendar and she would remind them to go on that day or the day before. It's a really simple thing, but management of those welfare managers changed. She left. The current ones don't do that. The letter gets put under their door or put in a file to collect from security when you collect your post. So nobody gives them the support to understand what that appointment is about. So a solution, would be that if something came with it that had something really simple about, this is your initial health appointment and this is how we create your record with the NHS. This is how we find out a little bit about your medical history and the sorts of things that you need. And there are optional vaccinations, whatever else is included in that. It wouldn't need to be a lot, and it wouldn't cost very much money to do that. But it's really simple. So I go into the hotel once a week. If people show me that letter, I do that explanation, but I can't possibly keep on top of reminding everybody, and I can't necessarily see every single person's letter and speak to them. So that is a really simple remedy, and I think that the way to deal with that is for the GP practices to try to build a relationship with the accommodation provider, and to try to make that happen. Basically, it's not easy. It's not easy working in partnership with accommodation providers, but it is possible to develop a better relationship with them. I think that linking with local charities as well. So where I have a link with a service, that can work quite well. So Sexual Health Sheffield, for example, we've got to know them quite well, and we can refer, and we can speak on clients' behalf and make sure, and that has actually resulted in them bringing a sexual health bus to the hotel, one of the hotels once a month. So instead of people having to go somewhere for an appointment, people are coming to them. And I think where that's possible, it really does work. And then I think that the final point is engaging people with lived experience in some way. So where that could be like a health champion, it could be a volunteer, it doesn't have to be a paid role, but having some way that people with lived experience feed back into the service or the GP practice about what the barriers are, and keeping it up to date, because things change a lot in the world of asylum. Things change rapidly. The way that hotels are managed, the people that are managing them, things change. So having that contact with people with lived experience who could be an advocate, because that's how I do my job. Without those volunteers with lived experience, I wouldn't be able to do my job, because people would not trust me or engage with me in the same way. So I think that if local practices and health services could make that link, whether that's through a charity or a project like mine or another one, with people with lived experience, that would really work. And I'd like to also pick up on what was said about reception staff. I think that is absolutely crucial, that reception staff know what messages the health professionals want to give out, because I've sat in the GP practice in Sheffield where most asylum seekers go, and I've heard people being really told off for being late or missing appointments. And maybe that isn't how the health professional would speak to those people. And I think it's a really stressful job. But we offer training, sort of awareness raising sessions, really, with anybody, with reception staff, with health professionals. And where we've done that has been a real eye-opener to people, to find out some of the reasons that people have difficulty in accessing a service. So if you've had sort of some kind of short shrift from a receptionist once, you'll not want to go back for your appointment again, because if you're 2 minutes late, you're going to think you're told off or whatever. So those are the solutions that I would suggest, and it's not easy, but some of them are relatively simple, if they can get agreed, like the leaflets with the appointment letters, for example.
So helpful, Caroline. Thank you. And Andrew, I've seen your slide deck for the research that you've been doing, and I think you've got some slides on this, that the ways that you develop to address missingness in your work. As I said, I think this might be on one of your slides.
Yeah.
Maybe we could bring up the slide and you can tell us a bit more about those ways.
Yeah, so thanks. So essentially what we did in this research was we pulled together what we could find from the literature, the existing research, and we did lots of interviews with lots of people, and we had a lived experience and professional stakeholder group to help us put together these interventions. And so we call them a suite of interventions to address missingness. And what we hope is it becomes a sort of framework for people to think about when they're thinking about addressing missingness. And and I think what I want people to try and do is hold in their minds the sort of things that Caroline was talking about there, because they all fit across each of these. So I'm going to go through them in turn. So the first is about embedding a missingness lens. So it's actually changing the idea that somehow patients are at fault here, and understanding that actually it's about services not being fit for purpose. And needing to change. Now that's a change that needs resourced, and it's about the way professionals interact with people, but it's also about the way systems are set up. And it needs to be thought about in the local context. So what might work in one GP practice setting might not be the thing that needs to be different in a hospital setting, for example. And our lived experience people were really key about this. They said that it's really important that there's proper accountability for this happening, because they're so fed up with all these lovely messages being said about the NHS, but then the actual reality being something different. Next bit of the slide, please. So the next part of this was actually it's about identifying patients at risk of missingness, so at the moment in health system records, we're still not very good at doing that at the patient level. And then it's about exploring the barriers, like Susan explained earlier about what the reception staff do in her practice, and then trying to work out what needs to be different for the individual person. But at the same time, that's about building relationships, because relationships are really key to all of this. And it's about building up an individual and a collective picture. Next bit of the slide, please. So then the next bit of this jigsaw, and this is one of the really vital bits as well, is this idea of missingness coordination. And Caroline's already described it, and so has Susan, what's happening in their context, or what isn't happening anymore and what could be happening. And it's this idea that there's actually either a person or a person who is part of the role to think about coordinating, so that actually this is an open-ended, flexible aspect of care. It's relational, and it's really about doing that bridging work that is needed to help bring the person back into the system. So I saw in one of the comments in the chats a person whose mum has multiple appointments scheduled across the same day for different specialties. So if acute care was to properly think about applying a missingness lens, they would actually have somebody sitting keeping an eye on that. And when they pick it up for a patient that there's multiple appointments being scheduled, they'll then sort that out so that the person either brings them all so that they're seen all together, or that a different arrangement is made. So that's an example. But also, really importantly, the social determinants of health are addressed in all of this, where if a person is struggling financially or has some issue with childcare, that coordination will help sort that out. And there's also quite a lot about advocacy, but also promoting system change. Next bit of the slide, please. And we've mentioned this a lot, and actually all of us have mentioned this, and it's to try and move away from the sort of quite procedural, transactional way that we're heading in the NHS, to actually understanding that relational care and relational access is really important. So that, and we need to be thinking much more in a psychologically trauma-informed way, and that might be around thinking about choice of who the person sees, thinking about continuity of staff, thinking about the person's communication needs. And my goodness, Caroline's, given a really, really great but depressing example of the health screening appointment communication that's made with patients newly arrived to the UK. It's thinking about the power dynamics and that advocacy work. Next bit of the slide, please. And yes, transport and logistics is in there. And so that's a sort of stepped, needs-led approach depending on context. Again, the example Caroline gave of the hotel that's really out with the city centre and really far away from services, that people living in that context might need a different response to people who are living in a hotel in the city centre, for example. But each service needs to think about transport and logistics from that point of view. And it might be that people will need a company to appointments, and it might be that systems around outreach or in-reach into different settings needs organised. Next bit, please. And then thinking about flexible scheduling for people. So actually for people at high risk of missingness, prioritising tailored forms of access. So choice of how people are seen, whether that's video, in person, on the phone, when they're seen, who sees them and where. And the actual need for longer appointments for some people, and maybe changed opening hours. But the really important thing is that this isn't seen as a sort of hassle that the NHS has to overcome, but this is seen as part of the NHS offer, which is routine care. Next slide, please. And this is a final bit of it. And it's this idea of contact around appointments. So reminders have their place for sure, but actually it's other bits around that. So again, what Caroline beautifully explained, the idea that people may well need orientated as to what to expect from their appointment. There might need to be an exploration, as Susan explained, of immediate barriers and how they need to be overcome. But the important thing is that this is all about being an offer again. And it's about checking in with patients and having an actual established point of contact for patients. So thank you. That's all of these. So I'm going to stop talking there and you could stop sharing the slides now. Thanks.
Excellent. Thank you so much. And I'm going to come back to Susan again. And for you, I'm going to ask, so with surgery seeing many GP locums come and go, and there being many vacancies, do you think it'd be good or not to, well, around continuity of staff, do you think this improves outcomes or not?
Well, yes, as I've said previously, and also as Andrea's pointed out, and I'm a practice because if I'm not there, I have a locum, albeit we try to get the same locums, and the same locums like to come back, interestingly. So maybe this is also a reflection of how the team operates in terms of communication skills. But yeah, the reception and the culture of mutual respect and trust being embedded within the practice itself means that that is then the staff look after the patients in that sense, and actually it transfers to the locum. And perhaps, we might make choices about locums who operate differently from that. And that's, I always feel aggrieved. I heard Caroline talking about, patients being reprimanded for being 2 minutes late, and this, it grieves me when I hear these things. Now, it's all very well for us to say, okay, reception staff, that's a bad receptionist doing that now, and that's a blame as well, right? Yeah. So it goes all the way through here. Now, we've also got to understand reception staff are human beings with their own issues and stuff that's going on in the background. So actually, the other part of it is the looking after, the caring of the carers. Now, that's also within the culture. I, know my reception staff as people with their families and all these things, and we accommodate their needs. And you know, we take them out, we have team building things, you know, go and see things that they want to go and see at the theatre. So there's I would promote that part of the reason behind where, you know, it would grieve me to hear that from many of my staff reception is to do with the fact that they are valued and trusted and feel cared for themselves, and therefore have the emotional capacity to give that out to others. Because without that, people just become burnt out and drained. You know, our staff are human, just like patients, and have their own issues. So that is extremely important. And then that means that locums and different doctors coming in, they can support them. And whenever I'm asking any locums or people to come in, you know, I'll mention, I said, you know, the girls know everybody. Generally follow what they might suggest to you, and it flows. And this is how we manage it. So it's absolutely critical. And part of the reason maybe why we also have a problem with sustainability in general practice itself is because GPs themselves find it difficult to feel cared for as themselves as human beings. These themes read right across everywhere. And into secondary care. I'm slightly to divert, but I'd forgotten about this anecdotal story. When I first was in general practice and I was within a practice and a hospital consultant phoned the practice, I didn't know the patient, to say this woman had attended with a very advanced breast cancer and then had not reattended for the appointment. And I spoke to the senior partner then, and the response was send a letter. Well, I was out there in that direction, and I went in and had the conversation with this particular woman, and she attended, and she survived that. It was a very advanced breast tumor, and she survived that. And actually, I ended up not staying with that practice, and she came to me and all her family. And yeah, so yeah, I've been doing this for a while, and that's the evidence.
Well, I think it is evidence because Susan, somebody's put in the chat that Susan has encapsulated the problems of missed appointment. She deserves a medal and might consider training courses to solve this problem. So, so brilliant.
Thank you very much for that. I'm not quite sure I'm up to it, but anyway, I could try.
I'm going to come back to Caroline, but I feel that this might already have been answered. So only answer this if you feel like it hasn't been covered, is around if you know of any good practice where you've seen where people are sharing what they're doing to reduce missed appointments. Any in like particular areas across the country or any specific places?
So, I mean, I think that one thing people can do is look at the safe surgeries. It's a scheme run by Doctors of the World, and you can sign up to be a safe surgery and display a poster, and it just has some simple things, advice in there. But I think there's quite a lot of discussion around that amongst those people that are part of the safe surgery scheme. And I think that in South Yorkshire there is a deep end group, collaboration is the word, I think, and they seem to speak a lot at conferences and fair health events and that sort of thing, and talk about that. There was someone based in Doncaster who was making a toolkit, which I can share when I know. I don't think
wonderful.
it's
Yeah,
launched yet. Is making a fair health toolkit that explains a lot of different actions that you can take, not just about missingness, but also all sorts of aspects of like trauma-informed care, basically. And when I know when that's launched, I'll send. I think it was going to start in December. So when I get information about that, I can share that with you, Sarah, and you can circulate it.
Brilliant. And I'm just seeing Yeah, Andrea says agree with the safe surgeries. Focused care workers are a gold standard. Fair Health has a soft launch, and so Andrea will post the web link, which is absolutely brilliant. Thank you for that. I think I'll come back to Andrea. I believe you have a template letter you mentioned for GPs and also CPD learning. So it'd be really good to hear about those two aspects.
Yeah, no, absolutely. And I think the really important thing to say from in terms of thinking about the framework for addressing missingness is that all of this is things that are being done already. And they're all things at different, so particularly in the inclusion health setting, like in services that meet the vulnerable needs of vulnerable migrants and homelessness, a lot of this stuff's been done. But what we are hoping with this framework is it kind of pulls it all together, and so that so that everybody can start thinking about this. And once I stop talking, I will put the Fair Health link in. At the moment, because it's only been soft launch, it's basically our CGPs sorting out all the stuff around it. But you can sign up to be on their mailing list so that you can get the information once it is all properly launched. What was I going to say? So we've got a set of films about the missingness work that are tagged to a CPD resource. It takes about 30 to 40 minutes to do, which I think hopefully would be helpful, and it's kind of focused around what you do already and what you think might be different in the context that you work in. And one of the initiatives that's happened in Scotland is something called the Inclusion Health Action for General Practice, and that was a wee bit of additional funding that Deep End Practices in Glasgow got to look at various aspects of trying to be more inclusive for their patients. And one of them was about assertive outreach, which was specifically about addressing missingness. And when they were meeting together as a group, they kind of realised that a lot of, we've talked quite a wee bit about letter communication today, but like the letters that, lots of people still get from their GP practice, which, is basically giving people into trouble for having missed appointments and saying lots of bad things. They've come up with a template letter that is the complete flip of that and is trauma informed and is doing all the things that we should be doing as an NHS. So that template letter is on the web page, and I've posted the link to that earlier on in the chat.
Brilliant. Thank you so much. And I feel that all of the questions I was going to ask each of you, you've done an excellent job of answering. And what I forgot to mention to those on the call is when you registered to attend this event, you submitted questions. So I've been through everybody's questions and I've tried my hardest to theme those questions. So the questions that you've heard me ask the three panelists today should hopefully have covered the questions that all of you sent in advance. And I've been looking at the questions coming through the Q&A and the chat today. So hopefully those will have been answered by the three excellent panelists. So I'm going to come to you and ask each of you one last question, but if there's also anything else that you feel you haven't mentioned so far, then feel free. So I'm going to ask each of you just one thing, the one change that you think would deliver the most impact to missingness. And I'm going to go to Susan first, please.
Well, I think Caroline and myself have both mentioned this, and Caroline said that there was a welfare manager and with a title for a patient services manager. Title isn't the most important thing, but it's the concept of having somebody within the team who will proactively engage and understand and facilitate with the patient. And through having that person within the team, that culture would percolate through the team.
Brilliant, thank you. I'll go to Andrea next. What change do you think would deliver the most impact?
So the obvious thing I'm going to say is use our framework, which I think is probably, because I think it does pull it all together really well. But I think for me, and we've kind of touched on this a wee bit, I think a bit of resource to follow it will be the biggest thing. You know, it's the mindset change with the resource to follow it, because, you know, people, professionals, people with lived experience understand what needs to be, mostly understand what needs to happen in their local context. So giving people a bit of the sort of time, headspace, money to do that, we know it makes a difference. I mean, if people are wanting a positive read, because my goodness, there's so many desperate negative things, then the independent first year evaluation of the inclusion action for general practice report is well worth a read, because not only did it make a big difference for patients, it also, I mean, lots of the GPs and other practice team members involved said it allowed me to do the job that I thought I signed up for. You know, so I'll stick that. I'm just about to post all the other things. I can't talk and
thank
put
you.
things in the
And lastly, Caroline.
Yeah, I mean, it's the same message really, as the other two speakers. I think just improving the link with the services that support the patients. So whether that is accommodation providers or charities that work with them, but just making that link so that there's people with lived experience able to feedback why something isn't working and what can improve it.
Brilliant. Thank you so much. If we bring up the final slide, please. And I just want to say a massive thanks to our three speakers, Andrea, Susan, and Caroline. I just thought that was absolutely fascinating. There was just such a wealth of information there, which everyone hopefully can take away today. The Patients Association has free membership and a free helpline should anyone wish to join us or can contact us. This session today is in the form of both a podcast and as a video on the Patients Association website. So please do share so people can listen in the best way that is for them. Thank you again so much, and I hope that everyone has a fantastic day. Take care. Bye-bye.